Hi, my name's Kathryn Van Abel, and I'm going to be talking about one of my favorite cases today, select neck dissection. We're most commonly doing this for metastatic squamous cell carcinoma, which makes up about 90% of all head and neck cancer cases, but certainly there are other indications for doing a neck dissection. We're going to start with marking out our surgical landmarks. First, we want to know where our mandible is. Then we can mark out a skin crease about 2 finger breadths or 3 finger breadths below the mandible. We want to do that in a natural skin crease. We can start off making a relatively smaller incision, and you can always expand that if you need to. I like to make sure I know where the external jugular vein is, both for good practice in case I'm doing a flap case later and need to preserve it, but also so I don't get into it inadvertently. So here's a nice depiction of those surgical landmarks. Next, we're going to inject. I typically use 1% lidocaine with 1 to 100,000 epinephrine, but that is certainly provider preference. We want to inject that just below the skin, trying to stay out of the major vessels to decrease bruising, which can obscure our landmarks when we get into tissue. Next, we're going to prep. I typically prep from at least the zygoma down to below the clavicle. We're going to get started making our incision. Tension, countertension is important. As we go through the skin, the first thing we're going to do is start looking for our platysma deep to our subcutaneous tissue. Remember that it's more obvious medially and it becomes dehiscent as you come far into the midline. Out laterally, when you're doing this dissection, you can start using a sweeping motion instead of cutting in order to find your great auricular nerve, also often your external jugular vein. When you're elevating the upper flap, I like to use double prong skin hooks. Over the EJ and the great auricular nerve, you can either cut if you have a clear view, or you can take a scissor and dissect parallel to those structures to create some space. I like to use a sharp blade, either scissor or a knife, for the upper flap to avoid inadvertent thermal injury to the marginal mandibular nerve. Next, we're going to use our skin hooks or fish hooks in Minnesota to ensure that we have good retraction. Here we have flipped our view in order to do our lower flaps. That's going to be similar to what you do in the operating room where you're going to change positions. Again, I'm going to use my scissor when I'm working on any structure that I want to preserve. I'm working out laterally there along the great auricular nerve. But because I'm not worried about the marginal mandibular nerve here, I'm going to switch to cautery. Again, using tension, counter tension with my assistant providing the counter tension inferiorly. I'm going to be able to operate just within that nice tissue right below the platysma. Once I've reached down to the clavicle, I'm going to turn my attention to the posterior flap elevation. I think this is something that can be nice in order to give you more mobility for your level 2 dissection and for retraction in general. You want to hug your sternocleidomastoid muscle, taking care not to injure the great auricular nerve that you tried to preserve or the external jugular vein that you also successfully preserved. I don't want to go much beyond the sternocleidomastoid muscle so I don't injure the spinal accessory. Now we've changed our view again. I'm standing in the surgeon's position, and what I just pointed out was the inferior border of the submandibular gland. Making spreads parallel to the gland, I like to be able to see the gland pooch out towards me, and if I stay inferior to this, I should be protecting the marginal mandibular nerve up within the fascia. Recall that we are doing a level 2 through 4 neck dissection here, so we will not be taking the submandibular gland. Once I've defined the inferior border of the submandibular gland, I can start working along the fascia to free this up back towards the sternocleidomastoid muscle. And in the process, I'm going to run into the common facial vein. In this case, it was a quite nice facial vein that we can see coming down inferiorly. But the area that I want to focus on is the space that lies just over my posterior belly of digastric. So of note here, I'm still just freeing up my submandibular gland. I'm not digging down directly inferior to that. It's a misconception that the digastric muscle is inferior to the submandibular gland. It actually sits just posterior to it. Here we can see the gland, the common facial vein, and the external jugular vein. We're going to ligate our common facial vein by dissecting on either side of it, exposing it to our assistant, clamping so that the two tines are facing each other, cutting so that there's enough space to keep the tine on. For a good tie, the assistant's going to lift it up so I can loop the tie around the tip, then rotate it so I can tie down right against the back of the mosquito, taking care that I don't catch anything I didn't want to within my tie. Typically, we'll throw a surgeon's knot for our second tie and a total of 3 knots down to secure the tie. This will be repeated on the upper branch as well. When you're looking for your posterior belly of the digastric, it's important to remember what it attaches to. So we are going from the hyoid up to the mastoid tip. We're going to lift the gland up and away because, again, it's sitting posterior to the gland, not inferior to the gland. For cases where you have perhaps a deep base of tongue tumor, trying to avoid a pharyngotomy is important, so not digging too deep in this area will be helpful for you. In addition, your hypoglossal nerve sits just below your digastric, so you want to keep that safe as well. So now we're going to follow the digastric all the way back to our sternocleidomastoid muscle. I think this is an important step, and it's easy to cut this short and then wish you hadn't later. We're going to be staying out of the tail of parotid, and again, following this all the way back. This creates an angle here, and we want to clean that entire angle out in order to maximize our retraction and view. So I'm going to do this by coming right along the sternocleidomastoid muscle, aiming down towards my digastric, and trying to stay away from being inferior to it, where I'll put my jugular vein and other structures at risk. Next, we're going to look for our hypoglossal nerve. We're going to look at where the hyoid bone and the stylohyoid ligament comes in to attach to it, or our digastric tendon attaches to it, and that creates a bit of an angle where typically our hypoglossal nerve will be found. This is an area to go relatively slow to make sure that you don't go into those radian veins and make sure that you protect your hypoglossal nerve. You'll have several bridging vessels that go over the hypoglossal nerve, often the radian veins like I mentioned, but also branches from the external carotid artery to the sternocleidomastoid muscle and our occipital artery as well. We want to clamp and tie these, taking care to protect the hypoglossal nerve underneath. Next, we're going to swing down some of the lymphatic tissue that sits adjacent to our great auricular nerve and inferior to our parotid tail. We're typically not taking parotid tissue with us anymore, but it's certainly something that we have to separate from the underlying lymphatic tissue. Here I'm showing you where the lymph node, this involved lymph node, sits here. Our next step is that we're going to want to follow the hypoglossal nerve out towards the jugular vein. Often people get stuck on this, trying to get their hand in the right position. You can do some exploratory spreads as long as you're fairly superficial there, looking for structures underneath such as the internal jugular vein. So again, it's important as we're following that hypoglossal nerve back towards the jugular vein that we take time to tie off any bridging vessels. This is because branches such as the occipital branch to the sternocleidomastoid muscle will result in pretty significant bleeding if we don't control it. Often, if you've done a good exposure, you can see all 3 of these structures, the hypoglossal nerve, the internal jugular vein, and the spinal accessory nerve, which can really ground your next steps as far as what your moves are going to be, where your boundaries are, and what you need to keep safe. All right, so next up I am going to divide my fascia both medially and laterally. We refer to this as opening the book. Our view again has changed here, so I'm looking across towards the middle of the neck with the submandibular gland to my right, and I'm going to be dividing the fascia, taking care to protect my hypoglossal nerve. I don't need to go beyond midline. Remember, up here we're technically in level 6. And that's not part of our dissection. So we're just doing this so that we can complete our lymph node dissection. I want to get down to my strap muscles and ultimately find my omohyoid muscle, which is going to be my highway over to the sternocleidomastoid muscle. Again, another one of those angles that we want to open up and clean off in order to adequately expose all of our structures. So here we're looking fairly inferiorly, following the omohyoid over to the sternocleidomastoid muscle, and then I can continue my fascial cuts up onto the sternocleidomastoid muscle. One of the questions is always where to continue that cut onto the SCM. You can think of this as almost like you're unwrapping the sternocleidomastoid muscle, and so I want to divide this at about the halfway point. It allows me to have something tangible to grab onto as I'm unwrapping the SCM. Here I'm showing you that I'm not going through the external jugular vein, and if I was doing a case where I really needed to preserve that, or if there was an opportunity to preserve it for venous drainage, it might be a nice thing to do, but this one crosses fairly inferiorly. So we're going to divide the external jugular vein Again, we have our 2 clamps and tie. I'm going to do my best to protect the great auricular nerve there, as I think that it can be a helpful thing for people to keep. Next, we're going to grab on with our coker clamps. I like to wait to do this until I have something useful to grab onto and not grab onto the muscle, otherwise it's going to obscure my plane of dissection. I typically like to use 3 clamps, have my assistant retract this straight up, and then I'll use my finger to walk this down as I'm dissecting with a monopolar cautery directly against the muscle fibers. I think it's also important to be able to use your cautery successfully by cauterizing the bridging vessels before you go through them. As we're coming over the SCM, we can use a band retractor to pull the SCM towards myself. And what I want to do here is I really want to keep an eye out for the internal jugular vein. And where that's at highest risk is inferiorly down towards the omohyoid. So that's why it's nice to know where that is and create some space. Next, we're going to move forward to try and find our spinal accessory nerve. The things that we really want to look for here are the tendon to the sternocleidomastoid muscle, typically about a centimeter inferior or deep to the surgeon, is about where you're going to be looking for that nerve. You're going to work slowly because this is an important structure to preserve. We can palpate for the transverse process of C1 and imagine that the nerve is going to be crossing the external jugular vein at about a 30-degree angle as it goes out towards the shoulder. And if we work slowly through here, you'll find some bridging vessels, and you can dissect right up against the sternocleidomastoid muscle, and you typically will find it if you use those landmarks. Just like with any nerve, we will really want to be dissecting right on top of it, turning our scissor up laterally, and then bipolaring it with good visualization of the nerve. Once we have the nerve traced out, we want to divide the tissue, both superior and inferior to the nerve, to free up the medial border of the jug. And then we want to do the same thing at the junction of the sternocleidomastoid muscle. Then we have our boundaries of the level 2B, with our skull base being superiorly, sternocleidomastoid muscle being posteriorly, and inferiorly is going to be our spinal accessory nerve. So we're going to be dissecting down to the floor of level 2B. We'll look at that a little bit more clearly in a second. You can use cautery here, or you can use spreads and bipolar cautery with cutting. You always want to palpate first to make sure that you aren't going to get into an ectatic internal carotid artery. And once you see that floor muscle, taking care that you respect where the course of your spinal accessory nerve is, you can move fairly quickly inferiorly. Sometimes you'll get into an occipital branch of an artery and you have some bleeding up there. I like to use an Alice clamp to grab onto this once I have some clearance. Here I'll show you an example of using scissors to spread, and then we'll be able to use a bipolar cautery going right over that bridging tissue, and then I can cut with a understanding of where my depth is down to my floor musculature. And this can be a nice hemostatic way to approach things. We're always taking care to lift the tissue up, make sure that we can see the spinal accessory nerve, and only cutting when we can see it directly. This is where having that tissue freed up both above and below the nerve is quite helpful. Here we're looking at the floor of our level 2B dissection with our levator scapulae muscle and our splenius capitis. Our packet is reflecting over the spinal accessory nerve. We can then make sure that we're staying above our musculature to ensure our packet comes out cleanly. And again, always looking where our nerve is. Next, we're going to dunk the packet under the nerve. I like to take a scissor and spread under the nerve to make sure that I've cleared up all of the attachments to the fascia. I can use my finger to dunk the packet underneath, and then re-grab with my Alice retractor so that I keep track of where level 2B is when I take out my specimen. So now we have to finish our level 2A dissection. This is a misnomer. People think that they're already down to level 3. They're not. We need to really free this up if we're going to be able to follow out any cervical rootlets and do a meaningful level 3 dissection. So I want to take care to release this packet off of my jugular vein and carotid sheath structures, taking care not to dig deep to this and get into the vagus nerve. We can free up the fascia on top of the jugular vein. This is going to be handy down the road when we're trying to unwrap our carotid sheath structures, as we have a visual mark to our superior extent of dissection. Once we've done that, we can come down along our sternocleidomastoid muscle, freeing up the fascia at the posterior border and looking for our cervical rootlets. Once we find one of those cervical rootlets, we're going to be able to trace this back to our now freed floor of level 2A. Once we find a rootlet, we want to remember the general course of these nerves and follow this superior medially back to the carotid sheath, freeing up all the nodal tissue superior laterally to it so that we keep our packet intact. This can be done with bipolar cautery and cutting. Once we've followed it back up to the carotid sheath structures, we stop. We don't follow it any further, and we can move back to the next most inferior cervical rootlet. And we'll continue this process until we have about 2 or 3 of these rootlets exposed. I don't go hunting too much for any additional nerve rootlets. As soon as I get inferior towards omohyoid, that's when I'm going to switch positions. Here we found our last nerve rootlet, and I'm following that up. You can see that we can have sort of a branching network, but we can see nicely now our level 2 musculature, sternocleidomastoid, our cervical rootlets aiming up towards our carotid sheath. And at that point, we typically have to turn our attention to level 4. All right, so now you can see we have completely switched your view, and that is what I'm going to do as a surgeon. I'm going to lift up my omohyoid muscle. I'm going to have my assistant place a retractor underneath it and help me expose my internal jugular vein. You can use a finger to kind of sweep this tissue down. What we've done is we've created an angle between the sternocleidomastoid muscle and the internal jugular vein, with the inferior extent being the clavicle or the transverse cervical vessels. If I am at the level of the clavicle and I haven't found the transverse cervical vessels, I don't go any further, and vice versa. This is to hopefully keep me out of trouble going too inferiorly. So once I hit the transverse cervical vessels, we're going to start moving our way laterally, keeping those intact. Next, after freeing up all that tissue, I'm going to take 2 sponges wrapped around my finger and carefully start sweeping that tissue off of the floor musculature up towards myself. Here you can nicely see the transverse cervical vessels, both the artery and the vein, coursing posterior laterally. This is sort of a scratching motion almost as you're moving the tissue off of the underlying floor musculature. You want your assistant to be following you and bipolaring as you move along. You're looking out for any lymphatic structures, and hopefully you've already divided the attachment so you won't be tearing any lymphatic structures. Often there's a branch off of the transverse cervical artery that comes up into the packet. That's important to ligate or cauterize robustly so that it doesn't bleed on you. We'll continue pulling this up and uncovering the internal jugular vein inferiorly until we have this sort of attachment out laterally. At that point, I'll put a Alice clamp on my level 4 dissection, again to mark it for myself for later orientation. So now we have sort of this attachment of our nodal tissue out laterally. It almost makes a point, and we need to find that last cervical rootlet and free it. Here you can see this nicely. So again, we've got our carotid sheath, transverse cervical vessels along the floor, where you have to be aware of our phrenic nerve as well. All right, now is for time for another change of position. I'm going to turn my orientation back so that I'm facing the patient. I'm standing on their side. And I'm going to start working on releasing or unwrapping my carotid sheath structures. I like to do this with an opportunity to view my jugular vein both superiorly and inferiorly. This allows me to keep my vagus nerve safe and to keep track of my level of dissection as I'm moving from deep to superficial within the neck. I have 2 opportunities here. I can use either a knife to unwrap this, or I can use a Jones scissor. It really depends on the situation you're in, the fattiness of the lymphatic tissue, things like that, and your comfort with a blade. But as we're coming up out of the depths of level 3, we want to make sure that we're always rising up and over the carotid sheath structures and not digging deep underneath the carotid sheath structures. I'm going to be looking for branches to my ansa cervicalis because that offers me a nice landmark to follow over the carotid sheath in most instances. Sometimes this can go deep to the jugular vein, so you always have to be aware of that. But basically what I'm doing is I'm trying to come up over the top of the jugular vein, keeping all of my lymphatic tissue with me, staying out of my carotid sheath structures. Depending on your neck and your assistant, sometimes having your assistant pull that tissue away from you can be helpful. Otherwise, sometimes I like to be able to manipulate it myself. Here you have a nice view of your jugular vein, your vagus nerve, and your carotid artery. As we come around to the medial surface of the jugular vein, we're going to start to run into branches of the jug. Depending on the caliber, these can either be bipolar cauterized or ligated. You always want to leave a little stump on the jugular vein so that if it does bleed, you have something to grab onto. Here I'm seeing a larger branch, so I'm going to start dissecting along there. And you can see that it's actually a branch to the common facial vein that we had previously ligated. So we're going to go ahead and ligate that. Because I'm leaving this part of the packet to my pathologist, I'm going to be able to bipolar on this side and ligate towards the patient side to try and prevent a hematoma down the road. Now I've got this packet sort of suspended off of my carotid sheath structures. I've divided it off of my strap musculature, and I have to finish off this dissection. I like to take this in my hand so that I can work on both sides of the neck. I think it's easy to get yourself stuck and feel like you have to always be working under the hardest part. But if you can pick up this tissue, you can often see planes that you can't see if you're just retracting it away from yourself. So moving the tissue back and forth, having a dynamic view of the underlying anatomy will be very helpful to you. In this area, we're thinking about where our superior thyroid vessels are. We're thinking about our descendants hypoglossy. We're thinking about protecting our carotid sheath and staying out of the vascular structures if possible. Ideally, I'd like to keep the descendants hypoglossy and the ansa cervicalis because it can improve our swallowing function postoperatively. It's easy to try and rush this part of the operation. Take your time, make sure that you're seeing your structures and protecting your vasculature. This is always a part where you can accidentally get into jugular vein because you just are running a little bit too quickly. I'm going to free off these last final attachments, and before I do so, I want to make sure that I have a good understanding of my orientation of my packet. It's typically fairly straightforward to reorient, but sometimes it can be a little tricky if you don't have some markers and you haven't sort of sorted it out before you take it out of the neck. Here will be our last part of the dissection within the neck where we can take this tissue out. As I said, it's important to orient. I've got my Alice clamp up top on the 2B packet. I've got Alice on level 4. So then we're going to orient this on the table. I know where my level 2B packet was, and that's sort of going to be my reference point because I can always see where the indentation from spinal accessory was. And then I know about my angle and about the quantity of tissue that I had in level 2A, so this gets marked out as well. Next, I'm going to look for my level 4 division because, again, you have a sense for where your Alice clamp was and the amount of tissue you had there, and then everything else is going to be level 3. But I think marking this out is helpful for our pathologist and helps ensure good communication. Next up, we're going to take a look at our wound bed. Carotid sheath structures where you can see that we kept our superior thyroid vessels. We've got our sternocleidomastoid muscle, our spinal accessory nerve, our hypoglossal nerve. Next, we're going to irrigate the wound, look for any bleeding that we missed initially. We're going to use a suction drain. I usually use a 10 flat channel drain for a full neck dissection. I like to have the exit point of the drain up towards the hairline, so we try and hide that from an aesthetic standpoint, and I secure it to the skin using a suture. As you're putting it through the drain, make sure that you're avoiding things that you tried to protect the first time around, so great auricular nerve, external jugular vein if you were able to protect it. We're going to tuck that down into the gutter, making sure that we're collecting blood from all the areas that it could pool. And then I'm going to begin closing. Typically this is in a layered fashion, making sure that I can close the platysma muscle. Sometimes we do this closing platysma and subcutaneous tissue, but I think if you get at least a few tacking stitches to the platysma to make sure things are lined up, you'll have a better aesthetic outcome. I use 4-0 Vicryl. I think it absorbs nicely, and then follow that up with some Dermabond. In summary, the neck dissection is a complicated surgery. I think that we can do it in a way that we can preserve as much function as possible by knowing our anatomy. There are some key surgical maneuvers, making sure you follow out all of your structures to open up angles, to improve light, using your surgical assistants to improve your tension, counter-tension so you can see your surgical planes. All of those things will help make for a successful operation.